get started in just about 2 or 3 minutes. So thank you for being here on time, and thank you for bearing with us. We are excited to have this conversation with you all. Start in just about 2 minutes. Recorded. If you have any objections, you may disconnect at this time. Thank you very much. And on behalf of the National Cancer Institute, I wish to welcome everyone to today's Implementation Science webinar. We are excited to be joined by our speakers, but before we get started, a brief word about logistics. All lines are in listen-only mode. We ask that if you are not already on mute, to please keep your phone on mute for the duration of today's presentation. As mentioned, the session is being recorded, and muting all lines will help us to avoid any background noise. We encourage questions and comments. Questions can be submitted using the Q&A feature on the right-hand side of your screen. Type your question into the provided Q&A field and hit submit. Feel free to submit your questions at any time during today's call. We will be using the chat panel to share resources throughout today's talk. Note, you may need to activate the appropriate panel using the menu options found at the bottom of your screen. If you require closed captioning, please refer to the Media Viewer panel or the link that appears in the chat box. You will be asked to enter your name. Lastly, we recommend navigating to the View menu at the top of your screen and selecting Hide Non-Video Participants, as this will give you the best glimpse of our great speakers. And with that, I will turn it over to April. April?
Hi, good afternoon or good morning, wherever you may be. And thank you very much, Sarah Bernal, on our implementation science team for getting us started here. Welcome, everyone, wherever you may be. Thank you for joining us for this Fireside Chat entitled Joining Forces, Engagement Science and Implementation Science to Advance Health Equity. My name is April O, and I'm a Senior Advisor for Implementation and Science and Health Equity at the National Cancer Institute. I'm super excited that you're here today and that we have this exciting with us. This session is part of a 3-part series that we've had starting from the beginning of the summer, and thinking about ways that we can use implementation science and apply implementation science as we work towards advancing health equity through the tools, models, frameworks, and methods that we have in implementation science. And in this session, we're hoping to have some time with our panelists to reflect on transdisciplinary approaches and how they can contribute to reducing health inequalities. In our first webinar and in our second webinar, there's a consistent theme that was brought up by our panelists around the role of stakeholder and community engagement in particular, and how to bring those perspectives in as true partners in the work that we're doing in implementation science. There are questions and opportunities to think about how we advance equity by also thinking about power, trust, and ways to facilitate true collaboration as we work across multiple contexts and with and in different populations. So today what we have is a fireside chat. And in our virtual world, the idea is that we might be having a conversation around a coffee table or around a fireplace or a fire pit. The idea is that it's a casual conversation where we are learning from each other and responding to different ideas together as we're trying to identify and working together to identify that transdisciplinary intersection between engagement science and implementation science. So I'd like to introduce our panel today that are here today. And I'd like to share my gratitude to all of them for the leadership that they have provided in the field, and also for sharing their time and expertise. So first we have Dr. Melody Goodman, who is Associate Dean for Research and Professor for Biostatistics at the New York University School of Global Public Health. Second, we have Dr. Paul Meisner from the Albert Einstein College of Medicine at the Montefiore Medical Center. He also serves as an associate in the Department of Family and Social Medicine. Dr. Lorna Houghton McNeil has also joined us from the University of Texas MD Anderson Cancer Center. Dr. McNeil is professor and chair in the Department of Health Disparities at the University of Texas MD Anderson Cancer Center. I'd like to also invite our moderator, Dr. Aubrey Villalobos, who at the National Cancer Institute has been leading work on our IS team in thinking about engagement applications and implementation science and cancer control. So welcome to our panelists, and I'd like to toss it over now to Aubrey to begin our fireside chat.
Thanks so much, April. Again, echoing April's remarks, thank you all for being here and for your leadership. Let's start off today by getting to know a bit about each of your areas of expertise and the unique perspectives that you bring to the conversation. Could you take about 5 minutes or so to describe how you view the intersection between implementation science and engagement science to advance health equity? Dr. McNeil, do you want to start?
Yes, and thank you so much again for this invitation. I'm really excited to, engage in this topic of conversation with such, esteemed panel. So I've been, doing community engagement work that has lots of names: community-based research, community engaged research, community-based participatory research. All of those terms that have been used, and working as an interventionist since about 1995, so about almost 30 years. And I started that work in North Carolina, working with African American churches there, and working on a colorectal cancer study, and I'm trained in public health. And I've been doing that kind of community engagement research, ever since then. And most recently, when I came to Houston, I started a long-standing partnership with African American churches, and I'm in Houston, that we call Project Church. And so now it's been going on, I guess, for over about 12 years. And over that time, we've worked to develop trust amongst our different entities, the Cancer Center, the faith-based organizations, and have done everything along the spectrum of community engagement, from outreach and education, all the way to what I would consider to be, full participation. And so, and everything in between. And then so I've learned a little bit about what some of the needs and the desires of communities are, and how, as researchers, we can collaborate, better in that area. I think engagement science is great to have this conversation about implementation work, because for me, they're kind of one and the same. I suppose that, yes, you theoretically can do anything without community engagement, right? But I think from an implementation perspective, the goal is to achieve the greatest impact. And I definitely think COVID has been a wonderful example of the need to have these partnerships and relationships and this trust already really ready developed, so that you can quickly implement things in communities where people need them to save lives, and not just, sort of for theoretical purposes, but in order to truly, make an impact. So I think it's a good time to be having this conversation, and these two areas, I think, really nicely intersect.
Great. Thank you so much. I really appreciate that, Dr. McNeil. Dr. Goodman, your thoughts?
Yeah, so I'm a biostatistician by training, and I've been doing community engaged, community-based work for over 15 years. My colleagues tell me that officially makes me a unicorn, to be someone like me in this space. But I think for those of us who are really interested in health equity, engagement is just a natural component of the work that we need to do. It's almost impossible for me to think about how I would do this work without including engagement. And I think because of my own experiences in engagement work, often having to go into communities that already had preconceived ideas about the institution that I was coming from, a lot of my work has focused on really trying to enhance the infrastructure for community engaged research, helping to increase research literacy amongst community-based organizations, and help them really build their own capacity so that they're able to engage with academic institutions as equal partners, having an understanding of what's going on, having a clear understanding of what potentially the benefit is for them and what the risks are, often more importantly, and really understanding how to be fully engaged in the process and speaking up and advocating for themselves when things are not working correctly. And I think this work is so important because it's really helped us build trust in communities. It's helped them, it's sort of teaching people how to fish, right? Help them understand how and why academic institutions are doing the things that they do, and how and why these things could benefit their community or people that look like them. So obviously I could talk about this forever. I'm extremely passionate about this type of work. And I agree with Dr. McNeil. I don't really see how you could do implementation work without some component of engagement, because stakeholders are often key and how things are done in implementation science. And there's a whole slew of different types of stakeholders that must be engaged in the process, I think, for it to work well.
Great, thank you so much. And I think we'll definitely dig into some of that as this conversation unfolds. Mr. Meister, do you have things to add from your perspective working in a health system?
Yeah, well, I come from a marketing background, and this is a sales kind of thing, right? And implementation science really is selling ideas to people to do and asking them to do it. And so, for me, engagement is the key. It's the glue to the implementation science kind of stuff. And, from the marketing background, you have to look at, see with whom you're trying to engage and what they're interested in and what it is that they will be interested in buying and doing and how they're going to do that. And I've spent my whole career doing this. And the one thing I'll say about it for me, I came to a point recently, I'd say, where I recognized that we needed to kind of apply science to it and not just do it. And so, that's really the thing that I've become quite interested in.
Great, thank you. So maybe a more systematic approach to engagement. That sounds like a good idea, I think, and we'll dig into what that actually looks like. So thank you so much for sharing. I think with that background on how kind of implementation science and engagement science are intersecting and connected, intertwined, I'd really like to get into some specific examples to make it tangible for the audience. So can you talk a little bit about what opportunities and challenges you've encountered in your work integrating engagement as a method or approach to advance health equity through implementation science? Dr. Goodman, do you want to kick us off on this one?
I think often the biggest barriers are time and resources. Meaningful engagement often takes time. Grants often don't give you a lot of time. And so we're often in these sort of competing demands. And I think meaningful engagement takes resources, right? Like making sure that your community partner has what they need to be engaged in the work that you are doing, including resources and staff and the like. And I think where partnerships often go wrong is they don't spend the time developing the partnership before they try to start doing work together. And I think the time that it takes to develop the partnership for many of us has not been built into the academic model of how to be successful as academic researchers. And so it becomes a side job, I think, in some ways for many of us that, we're doing engagement work because it's our passion and we know that we need to lay the foundation for future projects. But often I think that work is not recognized about how much time it actually takes to build the types of partnerships that we need to do the type of work we want to do.
Yeah. Others, Dr. McNeil, you've kind of have been doing this for 30 years. What are your thoughts, opportunities and challenges?
It's the same ones, that I would say, but that it's gotten easier over time. See, the notion of working in communities is not so much, difficult, even when I think you are working with a community that you are not necessarily a part of. I spent most of my career working in African American populations, and I am African American, but I'm not of that community and of those groups of people. And so I would say, like, even when I was spending time developing partnerships with churches, I spent like 2 years, right, talking to the pastor and really having him get to know me. And he was trying to identify, can I trust you? You're coming from this academic institution, which in our case, not in other places that I've lived, but in this case, it was a good brand, meaning MD Anderson was favorably seen in the community versus others that have been trying to do this work where that cancer center hospital is not trusted. And so you have to, sort of overcome those barriers. But part of that whole process of developing that partnership was trust. And as Dr. Goodman said, there is no shortcut for that. And so you are there, every Sunday that you can be. You are being responsive to everything, but that's normal. That's normal activities that you would do in building trust and relationships with anyone, and that seeing communities and stakeholders as other than is a wrong way to go about it, because you would require that type of level of relationship building if you were going to trust somebody to watch your child, or you're going to trust, somebody. So it's a similar, process from my perspective. But once that trust and relationship is there, and I've worked with many more churches ever since, it gets easier and quicker over time, because there's somebody now to vouch for you, vouch for that you show up, you do what you say you're going to do, you're authentic. And so while yes, it took a while initially, the fruits of that labor is completely evident today. And I'm able to then serve as liaison to others and other faculty, other researchers that are wanting to make those connections to communities, because I don't ever want to be the only one that's sort of in that space. It is to create a big tent and to have more folks who have this type of spirit and desire in mind do so. The last single thing that makes it easier is funding and attention to this particular issue. I went to say that I went from, sort of doing cancer disparities where kind of got pat on the head. Oh, isn't that cute? She's been doing that for like 30 years. And now I'm everyone's best friend. Everybody wants you to sit at the table. Everybody wants to talk to you, engage you. The problem with that model is that you haven't built enough of me's in order to really be able to, extend that work. So now I think this is where the new challenge is continuing to grow and develop, the folks that are on this panel and others to be in relation to communities and be responsive.
Great. Thank you so much. And, I want to ask Mr. Meissner, there's some different contextual considerations when engaging patients and clinical stakeholders that are going to be very different from how maybe Dr. McNeil's engaging in faith-based communities. Do you want to speak to some of the challenges or approaches that you've taken in that context?
Well, I wanted to comment a little bit just on the last topic, in that, a partnership in engagement is actually aspirational, right? We want to achieve partnership. And so when we look at different stakeholders, we also want to kind of move along a continuum of engagement, from just communicating with them all the way up to like being in a co-production function where they are really, involved in the production. And so I think that, we need to look at different stakeholders, that they have different perspectives, they have different motivations, and we have to understand that. And then I think the particular skill then comes in how to bring it all together. And one of my experience, you can do this individually, but you can also do it collectively. And where you have all the different stakeholders participating jointly. And if you can achieve that, you get a really nice result. Sometimes you just get, I call it like serial engagement, partner after partner after partner, and stuff like that. And you're the only one who then knows the whole. And so I've been very interested in trying to bring the different partners together. And terminology is important too, because partner, stakeholders, all of these different titles. And each one has a different role. And so it's really important to kind of assess them, work with them, find what they're interested in. And these are, and there are lots of different strategies, I'll say, everybody's kind of different.
Yeah, so I want to bring in an audience question here that came in that I think is relevant to what Dr. McNeil was saying before, but you all represent different institutions, right? And come from different communities. So, as investigators, the audience question says, we represent our institutions. Dr. McNeil mentioned trust and the reputation of MD Anderson. What suggestions do the panelists have for facilitating trust if our institutions don't have a reputation or a trusted brand with a community yet? Do you have suggestions or ideas for some first steps? So whoever wants to take a stab at that.
I'll say something about that. I think that we can't always be out front. And that, some engagement is a real process. And we have to sometimes start kind of in where we're the learners, and we can. And so when you don't necessarily have a brand and aren't really trusted, you have to build that up. And I think you have to understand that it's a continuous process, that it takes time. I think, as Melody was saying, it takes resources, and it takes skill, it takes patience. And, one of the things I point out often is that this is not necessarily a researcher skill set, that and that you have to start at a more um, in listening mode rather than in trying to achieve something mode.
So I've been at a couple of institutions where they did not have a great reputation, as Lorna says, MD Anderson did. And I think what Lorna said is true about any relationship. There's a great poem by Robert Fulghum that says, all I need to know I learned in kindergarten. And I feel like that's true about stakeholder engagement. It's just the rules of being a decent human being. Be nice to people, don't take things that aren't yours, clean up your own mess, put things back where you found them. It's some standard rules. But one of the things that I found most important is to be willing to, at least when I arrived, I didn't know the instances that the community had. And so I, one, acknowledge them, like, yes, these things happened. Two, I was patient and listened to their experiences so that I could understand their perspective. And then three, I was really honest. I kind of said, like, I'm sorry that happened to you. Here are my intentions. And let's figure out, how we can collaborate together. But I think it's just being a good person and not discounting people's experiences.
That's great. Thank you. Thank you for those thoughts. Lorna, do you have additional thoughts?
Just
I
the
think you're-
notion
yeah, go
to do what both, Melody and I think Paul is saying, to do both simultaneously. Ultimately, you have your research area, your interest, the impact that you'd like to, sort of make on the particular community, whatever skill set that you have, whatever you bring to the table in a partnership. If it's valued and valuable to that community and that partner, they're going to want to work with you if you show up and do what you're supposed to do. But at the same time, to be advocating that your institution has to step up and have to do better. So I mentored lots of junior faculty who are being brought into institutions as the one that's supposed to change the whole dynamics and the interactions and the relationships with the community. And that's a no. You're not going to be able to do that alone, I think is what Paul said. But that institution has a role. They have to step up if they want you to be successful, right? And of course, if they want to actually have a true impact on reducing disparities and improving, health equity. So to the extent that you can as well, appeal to those leaders that they have their role too. You can only do your part.
Yeah, no, and I think, let's come back to institutional supports towards the end. I want to come back to you. You all have mentioned trust and building trust in that longitudinal relationship. I think given the history, right, both past and contemporary, of how minoritized racial and ethnic groups in particular have been unjustly treated, we really have to tackle these challenging issues around power and trust and mistrust. And so, there's an audience question that I think ties into that. And it says, do you have any experience or guidance on how to reconcile evidence-based interventions, in quotations, and grant expectations with what community partners know, want, and need? And so I think this is really, it's a question around potentially competing interests among stakeholders, or just this challenge of how to balance different priorities and the way we value evidence, right? And how do we generate evidence, and what do we consider evidence? Who wants to tackle this one first?
I guess I'll answer it from this perspective. While I understand the question partially, I guess on some level, I don't, based on the kind of research that I've been doing. So the notion of community-based or community engaged research is that, you have either received some level of input collaboration, as Paul mentioned. There's a continuum, let's say, about how you kind of get that feedback within that process. And so the notion that I go in with anything is that things are going to need to be flexible. Things are going to need to be changed in real life. And we do it anyway. When we seek out to do a study and we want to recruit and recruitment doesn't work, we quickly pivot and try other things that we didn't specify in our grant application that we were going to do, but we are going to do whatever it takes and engage different people and places. So there's always a notion that research, from my perspective, is flexible and it's not static based on what you wrote in a grant application. So I just always feel like there's that latitude there. So I don't have a conflict between a funder and a study unless I'm changing the entire study. And then if so, obviously I didn't have the right engagement to begin with. And I proposed a completely wrong study to begin with. And I suppose that's probably rarely happened, but all kinds of tweaks to the intervention and tweaks to the approach that do not mess up the design, that does not detract from, its rigor at all, has only served to enhance the intervention.
Great, thanks. Any other comments on this one?
So yeah, I agree with Lorna. I think, the goal is usually to do good science. And engagement has always made my science better. It's made it more realistic, more intentional, more purposeful, and I think more meaningful in terms of, being placed and based in ways that are rich. And often the research question is to have some improvement in something. Like, we think about these tiny little research, but the goal is usually to see some improvement in something. And ultimately, if you're engaging the right people, you will achieve the grant aims.
Great. Go ahead, Paul.
No, I was just going to agree with that. I think that it's a very important process to be thoughtful about and to be planned. And I think Lorna was making the point also that at some point you react to the circumstances.
Yeah, no, I think that's right.
Aubrey, this is Sarah. If I could jump in for a moment, I wanted to take a quick second to thank those who had submitted their questions. This is a great conversation, and remind folks on the line that you can submit your questions at any point in time during our conversation using the Q&A feature on the right-hand side of your screen. We are aggregating those, and we are going to move through as many questions as we can during our time together. Thanks for the interruption.
Yes, no, thank you, Sarah, for helping sort through the quickly moving Q&A box. Keep them coming. We're really enjoying these. So let's see, I want to pick another one here. So can we come back to trust for a quick second? Someone was wondering, some really concrete strategies to get your university or cancer center to step up and prioritize community engagement. So, I know that's a big focus for NCI designated cancer centers and the community outreach and engagement component and requirements there. So that's coming from NCI on that's a priority, but have you all had any experience in how to get your institutions to really step up?
My previous,
Go ahead, Holly.
My previous position was at Siteman Cancer Center, and I actually found that they were quite receptive once I had a model up and running and some demonstrated data. In terms of understanding, I think the benefits of community engagement, I think many institutions do. I think what they don't know is how to do it. And so if you bring them this is what I think we should do, I find that people are generally receptive to that if it's a feasible idea and doable at the institution.
And I'll just add that it has to align with what their priorities are.
Lorna, were you going to say something?
Well, and at least for NCI designated cancer center, their priorities are aligned with that funding from NCI, right? And so they have definitely started to mandate more that cancer centers know who lives in their catchment area, what the problems are, and identify solutions to those catchments. We cannot just be focused on the people that come through our doors, who often are not primarily those that have lower incomes or are uninsured. And from a review perspective, they're stepping up the criticism and expectation that we're all going to be doing, a better job. And so I'll take it from others who would be able to say whether or not they think that they've seen significant progress from these new directives from NCI. But in my time at the Cancer Center, I want to quite say 180, but I will say a definite significant change. I do agree that my Cancer Center has always put money and resources towards community engagement, but the scrutiny intensity on what we're doing now is on a different level, and so greater resources and intentionality are coming with it.
Yeah. So I want to come back to what Melody said. You mentioned data. So I want to talk a little bit about, measuring engagement and some of the constructs related to engagement science that we want to bring into implementation science. An audience question came in that specifically asked, curious to understand more how trust is evaluated in community engagement. Is it measured in the sense, like, do we sense trust? Is it assumed because the project moves forward without, how are you all gauging trust? And then I'll come back to kind of following up on the second part of their question. But let's first talk about some of the challenges and opportunities around engagement and measures of engagement, and specifically measuring trust, which I know we talked about a little bit on the prior webinar, but let's talk about it now.
So we've been working, I've been working with some collaborators to develop a tool to quantitatively evaluate the level of partner engagement in research studies from the partner's perspective. And it's based on 8 engagement principles. And one of our engagement principles is around trust as a key component. I do think this lends itself to something that Paul said earlier, which is, we use these engagement approaches, but we really have to start thinking about engagement science itself. And really move our field from best practices and lessons learned to evidence-based strategies. Who do I need to be engaging? How much engagement needs to happen for this particular study? Like, really embedding it the way we think about our study design, thinking about engagement in the same scientific rigor as we do with other things, and also evaluating it with that same rigor that we would evaluate other things and other parts of our studies.
I'll answer it also by just saying, you need to build the skill set, and not everybody has Melody's perspective and understanding of this, and that this is a process, and then people are they're surprised by how difficult it is and how challenging it is. And so, I think that there needs to be kind of an understanding that this is a core function that we need to, we not only we need to fund, but we need to encourage people to access.
Yeah, no, great. And if you're following along in the chat, there are a few new references in there that April's pasted in from the development and validation that Dr. Goodman just mentioned of the research engagement metric that they have. There's one more link that's forthcoming to the actual website where the tool is housed, if anyone wants to explore that particular tool, the research engagement survey tool. So to continue on measuring trust, which was the specific audience member's question, they commented that it's important to pay attention to this because sometimes the way securing trust is talked about seems at times as if it could be exploitive, right? Secure trust to get the work done, or convince a group to trust us so that they will do what we want them to do. And that, I think is definitely not the kind of trust that you all have talked about building over these long-term engagement that you've done in communities. So any additional comments on measuring trust specifically?
To the extent that we want to quantify things and even qualitatively, sort of say that we know that trust is built. I completely, I understand that. And, would love to figure out ways to do that in my research, in my work, more to the extent that I've applied, sort of a survey approach, let's say, to it. There was always a ceiling effect. I mean, and I don't know if it's because there was some already prior relationship, prior work done in terms of, who you're engaging. There weren't necessarily like cold calls. And so by the time you do kind of pre-approach, there's a certain level of trust to begin with, and incrementally, sort of it increased over time. So it wasn't that valued, in a way. And it was more notions of, I don't know, do they answer the phone when you call? Do they respond to your email quickly? Can you get a meeting with folks? And I think that goes both ways, right? So that this notion that researchers are really busy, it's hard to get our attention, can they get my attention really quickly, as well, and vice versa are these kinds of ways. And then of course, do we keep working together? Do we keep submitting grants together? Does the work keep going? But mechanism ways to quantify that, I think is important as well. To point where, it can be exploited. Of course, that's true for, anything, but I think as Melody stated to begin with, it's not a quick thing. I might, exploiting something that you get really quickly might be one thing, but something that took you 2 years to develop, you're definitely not in it for exploitative, sort of purposes, because you had to give a lot of blood, sweat, tears, so to speak, in terms of, sort of developing that. The sweet spot for me along the way is when you are enjoying yourself as you are developing, sort of these relationships, and partnerships. So I was fortunate when I started working with churches in Houston that these were really folks who had lots of capacity. They weren't new to this in terms of researchers wanting to come in and to want to work with them, and like to think, Dr. Lovell Jones and all the work that he did prior to my arrival here as well, in setting some other issues. So whenever I stepped out of bounds or did something that was challenging, I was told about it directly, right? So there was no shyness there, and being able to say, we expect more, you need to do more, that this is our expectation, for working with us, and vice versa. And so no, it wasn't something that was quickly done and built that you can then commoditize and sort of hand off. It was earned.
Great. Thank you so much for those comments. I think coming back to the institutions, an audience member says that it seems that often, where advocacy for community engagement lives is in this space of goodwill or good intentions or good PR or optics for the institutions. They're asking if you could comment on the evidence about community engagement, to help articulate explicitly how community engagement made a difference or was a key factor in successful research and getting to those outcomes. I know, Dr. Goodman, you spoke to this earlier about we need to do more research in engagement science to connect those the engagement strategies to the outcomes that we're looking at, both implementation outcomes as well as health outcomes. But does anyone want to comment on kind of where are we in what we know about why engagement is of value?
I'll speak for myself, but I think it has made me a much better scientist. I think when you have someone, when you have an idea of how things may work and someone says that absolutely will not work in my community, and then you have to work with them to figure out, how do I get you what you need, and how do I get what I need, and then how do we get what we need as a collective? I think it has improved the type of questions that I'm asking, the type of data and information that I'm going to collect. I think the thing that has improved the most is how I interpret that data. Like when we see something in the data and we go, well, this is weird, and a community member comes in and goes, that's not weird at all. I know 10 people who've had this experience and it's because of X, Y, and Z. I think just some of those things, even though what I feel is anecdotal, I just know that it's made me personally a much better scientist.
I think of it a little bit about in the stuff of recruitment for studies, right? I mean, the institutions are always interested in being more efficient and effective in their recruitment strategies. And, we can't continue to learn by doing and over again. And we really do need to learn, by engaging with the people we want to recruit and understand what's going to work for them. And I think that, I don't know if there have been any randomized controlled trials on recruitment, community engagement on one side, no community engagement on the other side, and see who recruits faster and more. But it would be an interesting study to try.
I'm sure we know what would win, right, Paul? I mean, hands down. I mean, that's what I think at the end of the day, how many researchers, want to partner with me and others that do this work because they tried it without community engagement. It's not working. And they're like, help me recruit, sort of folks to studies. I think this goes back to the science of community engagement because this is a really good question about what are our outcomes that we think is meaningful in engagement science and some of Melody's work as well. So when I heard that question, I thought, well, did research outcomes improve based on community engagement? Was there more funding because of community engagement that was brought into both parties? Was there more capacity being built on both sides due to community engagement? Is there, sort of more leadership opportunities for, so how are we advancing sort of the health of communities, but then how do we break that down into tangible, sort of outcomes? And so from a research outcomes perspective, I think that was Paul's point. I meet all the accrual goals for my studies. I have, nice outcomes, a nicely designed intervention. I do physical activity research, and they all, show improvements in physical activity, compared to a control group, for example. From a funding perspective, our community partners have obtained independent funding, because of the partnerships and being able to show in their preliminary studies, work with the cancer centers to say, this is how we demonstrate we can partner with academic institutions. And so now we should, give us funding to do the whatever research or whatever program that they'd like to develop, both on a leadership perspective to see the elevation of some of the churches and some of not even the pastors, but some of the folks that are serving as like the leaders of the health ministry. They're being invited to serve in different roles within their city and county because of some of the work that we've been doing, in partnership. Likewise, I've been able to, have a higher elevation and a greater voice in my cancer center because of the work that we've been doing. So I think when someone says, how do you measure, community engagement? And if it works, we can break it down to multiple different outcomes and impact that we want to achieve. And then to be able to see, have we achieved those types of things? And I just named, a couple off the top of my head where I think that we've made significant impact.
Yeah, no, I think that's really great. I'm going to move us on in just a second to a little bit more kind of theoretical conversation. But before we go, I want to talk a little bit about I've heard transdisciplinarity is like really key here. And one of our audience members commented that they have a really diverse group in their research team of, professionally diverse physicians, epidemiologists, community partners, patients, caregivers, and students. And they said, we have clear expertise areas for where everyone in each role contributes, except for students. So kind of in the spirit of some recommendations to the field for how we can continue to, grow experts who can do engaged implementation science, what specific skills or ideas would you focus on teaching or sharing with students who will hopefully become, talented researchers in this space?
When I was being trained, the best community engaged experience I had was working on community engaged projects, like being in the field as, someone either collecting data or just, doing the work. I think that's what, experiential learning, I think, is one of the best ways we can train our students, getting them involved in our work, asking them to do some of the engagement activities and having them participate in the engagement work, I think is a great way to start, at least.
Great. Other thoughts for trainees?
Experiential all the way.
Okay.
In addition to tangible skills, I think at least for me as a student training, what I developed was a sense of authenticity. I say that word a lot as well, like, how you show up and who you really are at your core when you are engaging with anyone, and how it really comes to bear in the relationships that you are, developing, trying to cultivate.
Okay. Great. Thank you so much. So I'm going to move us on. We may come back to some of the comments that have come in already as we have time. I really appreciate this discussion. And as you talk, I hear engagement being operationalized in a lot of different ways. It's a strategy, it's a methodology, it's an outcome sometimes. It's a research principle for advancing health equity, which is why we're here today. I'd like to talk a little bit more about how we can operationalize engagement in dissemination and implementation research specifically. What are some of the constructs, the theories? How do we incorporate it into our theories, models, and frameworks? What are your thoughts on really merging these sciences together to advance health equity?
Maybe I can start by saying I see this as a Venn diagram, right? And that you have a lot of overlaps on it. So that it sort of depends, and even in a matrix form. I think that there are then there are really opportunities to develop it as a science, but it's really to keep it in that matrix, and to really test out some of the different strategies and for different objectives within dissemination, within implementation, translation. There are just multiple opportunities in there with that Venn diagram kind of concept. And it's tricky because it's hard to differentiate some of these activities if it's a science activity or if it's just like a function. A function is a strategy and it could be tested. So I really encourage the thinking of the Venn diagram is the best way I guess I can put it.
Other comments on this one? What would you say? You've hinted at needing to study more engagement as a science. What do you think are some of the understudied areas or key research questions related to engagement for the IS field, the implementation science field, to consider? What would you like to see people working on, or what are you hoping to work on? And anyone can take a stab at this one.
I think there's a lot of questions, and we mentioned a bunch of them, but really, how does engagement impact the scientific process and scientific discovery? Does it impact the speed of recruitment, the diversity of the population in which you've recruited? How does it impact your science in other ways? And I think some of the questions that I've been thinking about is what level of engagement is appropriate for each study. And I think of engagement as a continuum, sort of from outreach and education all the way out to partnerships, which I think is like Paul said, a goal, but not necessarily a realistic thing to always have. But I have to be clear, like every study doesn't require a partnership, right? So I don't think we know yet what the right level is for different types of studies and different types of designs. I think there's a lot of science to be done in this space.
Those are great points, and I tell people that all the time. Like, start somewhere, but work your way if necessary. Needed towards full partnership. I've done a lots of studies, sort of in my young career, I guess. And all of the engagement was along a continuum. There were some that, sort of where the real goal was full partnership. But I've done outreach and education. I've done collaboration. I've done cooperation. I've done consultation. I've done everything along the way based on the needs of the community that you're working with, what they have the bandwidth for, what they really are interested, sort of in doing, whether the capacity to do, and really what meets the goal of the study and the research question that you're trying to, you don't ask and answer it, it's always not, sort of like the full enchilada necessarily, but, I think some input, along the way. And so we are spending a lot of time right now, I think, in our cancer centers at least, really trying to engage basic scientists in community engagement and wanting to better understand how can their science be enhanced by, sort of talking to, hearing from, learning from, getting direction from communities and their perspectives and the work that they do. And these are groups that you would argue don't even speak the same language. I barely speak basic science, right? But then you can imagine sort of implementers and people in community-based settings. And so that's a good example of what the science of that needs to look like in order for that group, that area, basic and translational research, to really have community input into their work. And I think some of that is being prompted in cancer centers, and CTSAs are also engaged in a lot of this dialogue and conversation. So there's science to be done with various stakeholders, not just communities, but research stakeholders in terms of who we are, what we do, and what is the right approach for us as well.
I'll say one thing about all this. So I had an experience with going to a very basic scientist and trying to talk a little bit about dissemination and implementation and engagement. And I was really interesting. I found, I didn't know anything about this. And what I did find out is that they very much work in a team science approach. But the team that they have is a very limited team of, just the next scientist over, basically, or their collaborator. And even, the biostatisticians that they're working with are pretty specialized, that this is their biostatistics field. And so one of the challenges is just to kind of help them broaden their the circle, right? And to go to the next level out and to understand who they're working with. And they get it pretty much, but it's very episodic, when they need it. And I think that one of the things that in research that we need to look at is how to maintain and sustain engagement. And I think and there are lots of dimensions to that. One of the things that I think we've kind of alluded to is how much effort does it take, and what's the right amount of effort for the engagement objective to really tie these things together are really important. And different stakeholders will have different understandings of what you're trying to do, and so they'll get exactly what you want right away, and you won't have to spend too much time with them. And others will take a lot more education and a lot more patience, and so you need to have different strategies. And I think that we need to somehow put this into a research and a science framework that will allow us to study it.
Yeah.
Can I just piggyback and say that, Paul, I think your example of it being team science is wonderful, because I think I think we were all arguing that this is team science as well, in terms of what we do. Everybody has a different role on the team, but institutions are leaning into team science, right? That's making great significant strides in terms of investments in team science, and adding, the notion of some community input within any kind of research team, I think, is gaining some traction. And you have some institutions that are requiring community input as part of their team science, and we definitely are. You see that more in our IRBs that say you have to have a patient perspective now, but I see more community perspective within the research that you're doing, not just from a human subjects perspective, but some from the science perspective as well. And so how can we apply team science approaches as well to engagement science and implementation science, because I think they have been making some strides in that area too.
I think you're right, putting it in kind of the leaderships, or some of the doubters language that they can understand the value. I want to come back to what you were talking about earlier with building trust and strategies for building trust. And Dr. Goodman mentioned that a lot of their work has been around research literacy and capacity building for community members to participate in these research teams, and developing that community infrastructure. And I imagine that kind of helping develop some of that, whether you want to call it, capacity, social capital, literacy, that is related to building trust, right? That's that mutual benefit of engagement. Does anyone want to comment on that at all, about how you've incorporated any capacity building, or how you've kind of helped to develop some of that community infrastructure that I think would lay the groundwork then for successful longitudinal engagement?
I mean, what I'll say is that communities already have a lot of these structures in them, and that what we need to do is we need to tap into them and not try to control what they're doing, but to have them, inform and guide and work with us. And you start with smaller projects and things that are doable, that have very short time frames, so that you really can develop relationships with them. And once you do that, you can progress along the level of complexity and over time. But I think that this is where we as researchers just need to understand the capacity of the community to do these things, and to utilize, this is kind of the assets approach, right? I mean, it turns out that we are the ones who have the deficits, they have the assets, right? And so, we have to recognize that.
Yeah, no, great point. Great point. Thank you.
I'll just say that a lot of our work around increasing research literacy and data literacy was done at the request of community members. And what I really saw it doing is helping them do what they were already doing better. But really what I think it did was give them some vocabulary that they didn't have. They were doing lots of these things, but they don't call it what we as researchers call it. They say, how are you going to do that? They don't say, what is your study design? But what I found is that when you're engaging researchers, particularly ones that are new to engagement, the way you ask a question matters. So if a community member goes, what's your study design? They're going to get a different response than if they go, well, explain to me how you're going to do that. That's not the community member's responsibility. Let me be clear about that. But I just think giving them some tools to engage with us, because I think the people who really need to be trained are the researchers. But I think the community members have been more receptive to the training. And so I want to be honest that I was training that group mainly because that's the easier road to go, because they were sort of more receptive to this idea of learning the shared vocabulary. But I think once they had the vocabulary, it enables them to engage with researchers in a different way. People just respond to people differently when they speak their language. But I think we as researchers have to be better about talking in plain language and engaging the communities in meaningful ways that we want to engage, without them needing to be sort of trained on how to communicate with us.
And this isn't, maybe not completely related to this whole conversation that we're having. I'm sorry, but it's triggered something in me because of word capacity and sort of what communities are interested in. But I'll never forget, I worked on a PCORI study, and it was asthma related, and I don't do asthma research, but I was there as the sort of community engagement methodologist, right, to kind of work with, communities. And we worked together over 3 years, maybe, on this particular, study. And all along the way, what I hear from the, community partners that were there was, this notion of, are we going to actually finish this? Are we going to actually do this, right? And 3 years later, here we are, we're still doing it. We're still plugging away. We're still, collecting. And then when it was done, it was like, wow, I've been involved in lots of research studies in lots of different phases, never was involved in one that actually finished, right? And it was interesting to me, because I think as scientists, we kind of, they're dead ends for us in lots of things. We have lots of interest because not everything materializes. And so we have another idea that we pursue and another idea we pursue. But this notion of longevity, continuity, sort of like finishing something is seemed as a really important value that I don't think that I had really paid that much attention to before, but it's always on my mind now to finish things, you know what I mean? Because it helps the next time they want to participate in something else to say that it was completed, whether or not it worked or, sort of it didn't work.
Maybe I can add to this that, we have in our communities a lot of medical mistrust and distrust in research, right? And I think, the engagement is really the antidote to the distrust. And not only that, but, as I think Melody was making a great point about the way you ask the questions and stuff. And so we get a lot of distrust research, and distrust research is very susceptible to the way those questions are asked. And you can ask questions in a very different way. And, we test those out when we talk to community members.
Mm-hmm. Yeah, no, thank you. Thank you for those comments. I think since, there's an audience question I want to bring in now. It says, could you discuss your experience in co-producing research designs or having participants as co-applicants? So really early in the research continuum, engaging community members, partners, potentially practitioners in clinical or public health settings. What has been your experience in engaging them early in the process?
We don't do it otherwise.
Yeah, that's just that's how I know and understand, right? I'm fully cognizant and aware. You only know what you know, right? And there's so much you just don't know. And the further removed you are from communities that you want to work in, the more you gotta know, in terms of, and getting that feedback, and that input. So from an idea phase, I have a gazillion ideas, and so routinely we'll share them. And as Melody said, that we're like, that one won't work. No, we keep working on that one. Come back, a little later when it's more, mature or, fully developed, or, oh my God, I like that. And, and continue that conversation and discussion. So much so that one of the things that we've recently done as well is sort of work with community members to help them provide that type of feedback into investigators on a large scale level where investigators can just come with ideas. It does not have to be, we don't almost want it to be, right? Want it to be in that early idea phase where you're just thinking about something and you kind of want to be able to, do that without having to develop your own quote unquote advisory board and do all the outreach yourself. Community members, this is a job that they get, they're consultants, they get paid to routinely and consistently, provide that feedback. And it's called different things in different places, community scientists or community, engagement studios, and they go by lots of different names in order to do that. But that early phase, I think many of us are recognizing the value in that and want that input, regularly.
Mm-hmm. Anyone else want to comment on this? And then I'm going to jump to the other end of the research continuum.
I'll just say, sorry, I'll just say that Lorna made a really important point there too. You have to build it into your structure, right? And so you have to pay them. We did a recent PCORI grant where we had a community member who was our community engagement specialist, right? And they were funded as part of our grant. And the other thing, and even in your structures that you have and the way your meetings are held and how you do things, you need to bring forward that voice because it's not always easy for community members to express themselves in a research community. I think it goes back a little bit to the vocabulary that Melody was talking about. Maybe they don't understand quite what's going on. They don't understand the implications of stuff. And so the other thing it takes is it takes facilitation skills to bring forward that conversation.
Mm-hmm. Yeah, no, that's great. So someone says a great point about completing things to foster trust. What has been your experience related to implementation sustainability? How do you keep things moving past the initial trial?
No hard questions allowed. We design sustainability, we write sustainability into all of our designs, and so of course do lots of activities to sustain and maintain that. But I jumped in, probably shouldn't have more to say. I think that's still, at least in my research that I do, like I said, physical activity research, still, a challenge, overall. The partnerships, I can talk about sort of ways in which those things are maintained and sustained, but sort of any one study, any one kind of thing that you're doing, how you continue to, have that be fostered without continued, funding is always a challenge, and always eager for examples for how to make that happen better.
Mm-hmm. I mean, I think broadly that's something that the field, the implementation science field, is is looking at and struggling with and trying to tackle too. How do we increase sustainability of interventions programs? Yeah. Anyone else want to comment on that? How they've sustained
the projects that have worked in terms of sustainability are ones that built sustainability into their structures up front. So we went into something thinking about sustainability on the back end, and we designed the intervention so that it would be sustainable post grant funding. That's often hard without resources, but when there's sort of people in place and nurses or whoever can take over your intervention, trying to figure out who those people are. But I definitely think it's a conversation that most people talk about sustainability in year 5 or whatever their last year of their grant is. I feel like you have to talk about sustainability in year 1 because you have to build something to be sustainable. You can't build something and then say, how do I make it sustainable later? I think that's a much harder thing to do anyway.
Yeah, no, I think you're right. Same, designing for dissemination, and you're, bringing the community members, community partners, organizations in early so that whatever you're working on implementing is more likely to be sustained. I think that's a great point. I want to move us on to our next big topic. So, if we're better integrating engagement in implementation science, I think you've alluded to some of these challenges already, and let's maybe think about them as opportunities related to grant writing, scientific review, and even grant administration with diverse partners. So coming back to the institutional supports that are needed to further this integration of engagement in implementation science, what additional institutional supports are needed? Or what would you want funders and scientific reviewers to know?
I would want funders to make it easier for community-based organizations to participate in the grant writing process, and also our institutions. I think some community-based organizations that I've worked with, I consider them like over-engaged. Like the university has gone to them so many times, but I understand why. They have the systems in place, they have the structures, they can get the budget out, they can get the subcontract in place. Everything can happen in the 7 days or whatever ridiculous timeline it is that we're giving them. I think in terms of institutions, I would love for them to give more support to our partners, the same way that they support us as researchers at their institution, to give some of that support to these partners that don't have that capacity yet, and really help them build up some of that capacity, because it can be a rate limiting step if an institution doesn't have a DUNS number, if they don't have some of these just things that we think are basic things to have, but to a community-based organization, they are not. Those can be rate limiting steps if they don't have the capacity to jump some of those hurdles.
Mm-hmm.
Things like bio sketches, whether or not they are needed, and whether or not some organizations allow you to, put a resume, or, instead, and then you got to get an ERA Commons number. And I mean, I think all of the things that, Melody, just alluded to, of course, make it challenging. And yes, we find ourselves engaging someone, over and over again. And you've got to, what I call, spread the wealth in this way, particularly when you're talking about doing subcontracts, and making sure that you're, involving as many people as you can based on, what your needs are. One of the other things I'll say too is, I don't know, not put out RFAs and say they're doing, the grant is doing 10 days. That has been happening a lot with health equity and health disparities research. This past year, in general, I feel like maybe, but definitely this past year, and not just always COVID related. So I get the urgency for COVID related projects, but just health equity research in general. And I think it's that kind of, oh, we have leftover money at the end of the year, and so we need to spend it kind of approach to health equity research. Or again, there's more scrutiny from NIH and maybe Congress around health disparities. Again, we talked about this thing's, now more of a popular area. But no, every other area of research requires thought and time. In order to write those grants, require you to meet with community partners, in our case, to talk about what that grant is and come up with a strategy, and that you cannot see the RFA and it's due 30 days later and, feel like you can be completely, responsive to that. And so that's been a pet peeve of mine for sure within the past 18 months, that we need to, remove that. And I get what the constraints might be, but I don't see how what we're doing is different than what other researchers are needing to do in terms of putting their teams together to be responsive, to grants. From an institution perspective, and we've already talked about this, that all of our institutions that we work on have got to step up. And so you have everyone's looking for a chief diversity officer now. They didn't have one before, but they're trying to get one. That's going to be a popular, job right now. Our community outreach and engagement, for our cancer centers, our community outreach engagement for our CTSAs, are taking, front and center. And so I'm looking forward to capitalizing on this moment. I don't know that it will last I don't know how long it's going to last, but, that between the murder of George Floyd and, COVID, it has definitely created some urgency. Many of us now can get audiences with our presidents and others that in the past, we wouldn't have been able to. And so I think what I'm interested in getting folks together to say, for those who have been able to capitalize on this moment in order to advance health equity in our communities, what have you found that has worked? What do you say to your leaders? What do you say to community organizations that get people to come to the table and actually put forth money? Pharmaceutical companies are now wanting, participating more heavily, and I, thank them for their leadership and investing, sort of more money in this area. But now we're in the, not quite, but, look up and say, oh, wow, seems to be different funding streams that weren't available to us before. Again, given the fact that they might dry up, and I fully anticipate that will, because it's sort of like the flavor, how do we, take advantage of that? But making sure that our institutions are part of that, investing and devoting some greater set aside funds than they ever had before, I think is an important responsibility.
Yeah.
Have you ever tried to get community-based organizations people city trained? And that takes a long time. And while it's interesting, that's a big investment on their part to do that. And I think we start at places like that, and we try to help them develop the capacity to be engaged like that. And then even making the way through all the different components of these kind of grants is a big challenge. And I think that we just have to recognize that we have to help foster their capacity to do these things, because otherwise we will go to our preferred community provider organizations, right? And they'll just be the same ones at all time. And it turns out obviously that there are other places that can do this. I run a practice-based research network, and so our network has the capacity to work with community-based organizations to help support them. So I think that's another kind of strategy, but it has to be structural, right? We're not going to just do this episodically.
Mm-hmm. Yeah, no, I think great points there. I want to bring in I think we have time for one final audience question, that kind of relates to the institutional research environment. What suggestions do you have when maybe a colleague hypothetically at your institution asks to partner with you or with a community that you've developed a trusted relationship with? We know this could be a thorny situation, particularly if you might have concerns that that your colleague or the research agenda, their work may not be in line with health equity goals or may actually potentially exacerbate inequalities through unintended consequences. So has anyone encountered any experiences like that, especially this year with the increased attention to health equity, and how do you navigate that?
I say no. I'm one, if I think it's not a good partnership, I'll just be honest that I don't think this is the right partnership. But to build a relationship with a community-based, or well, any person is a valuable relationship, and you wouldn't let anyone else come in and ruin that relationship. And so if I'm worried about that, I will just be honest and say, you know, I've taken time to build this relationship. I don't think your partnership with them is the right way to go. But sort of like in most things, your name is all you have. And if people use your name and tarnish it, then it's hard to undo negative impacts, I think.
I love that answer. I love that answer, Melody.
Yeah, well, you know, I mean, this is, you know, transferring the imprint, right, from me to my colleague, and so you have to trust them to do this. But the other thing I do is I go to the partners and I say, look, if you have some issues, come to me and let me help you resolve these with some of the issues. Because really, what also happens is that you there's no you can't you have to do it to learn it.
Yeah.
Yeah.
And I think it's also a fine line too, you know, and that has happened where it's hard. I don't want to be, I don't, what is the role of researchers when we've developed these relationships as a gatekeeper? I think to me that's a really interesting question because I can't do it all. You know, prime example, you know, lots of interest among African American churches that I work with in diabetes. Whereas I deal with the behaviors, right? As a cancer prevention person, of physical activity and diet, I don't really focus on diabetes. And so, you know, you have to bring in other folks who focus on hypertension or focus on, you know, diabetes and don't want to always be this gatekeeper coming, you know, through me, but they are coming through me in order to say, you know, can you help, you know, partner. And so depending on what that research is and the quality of that, and that whether or not it might really be helpful to that community partner. I also want them to have an opportunity to hear what it is and decide for themselves too, you know, whether or not, you know, it's something that they're interested in. And then there are other times, like Melody said, where it's just a no. It's, I, you know, don't think that it's a good fit. But I always struggle a little bit with this, what I feel like is a little bit gatekeeper role. Interested in Paul and Melody's, you know, perspectives on that as well.
I think for the most part, I let my community partners make the decision. But I'm open and honest with them. But if I know it's a no, and sometimes you know in advance, then I just say no. I'm not going to waste anyone's time.
Great. Thank you so much. I think we have about 10 minutes left with our time. So, you know, I'd like to close out by asking each of you for your thoughts on one thing you would want implementation scientists to take away from today's conversation to inform their work. And while I give you a second to think about that, I will just say there have been some really great questions and comments that came in. Everybody has been very complimentary about your conversation and your insights. So thank you again. We don't have time to answer all the questions. There are some really specific ones around member checking and facilitation skills and CBPR. And I'll just say to our audience members, we hope to continue this conversation in the future with more on implementation science and the science and practice of engagement. So, you know, keep an eye out for that. So let's start with Dr. Goodman and then get everybody's final thoughts.
So I guess I would say be as thoughtful and intentional about your stakeholder engagement as you are with all the other parts of the science that you're working on. I think we're really thoughtful about study design. We're really thoughtful about the right participants in the right place and the right recruitment. And I just want people to be as thoughtful about engagement in terms of who needs to be at the table in terms of stakeholders. And I think it could be really broad. What level of engagement is appropriate, And how do I bring in people that need to be here that maybe aren't here right now?
Great, thanks so much. Paul, do you have any closing thoughts for us?
That was an excellent comment, Melody. Stakeholder engagement is continuous, and it is not one-off for a research project. And so I think that that's one major point, and I'll say one other is that, and I've said it before, is that it requires a team, and that you need to have other people. You can't just expect that the researchers can accomplish this.
And I would probably say sort of like educate oneself as much as you can. And there's always this notion that other people need to teach somebody something. And whether or not, again, when I was coming up, called more community-based participatory research, and now there are new terms for everything. I recognize that the words change over time, but what we've been doing hasn't, changed over time. I feel like I've been doing same stuff as a graduate student in North Carolina, that I do now, that I hope I'm better at it than, sort of when I was, a student. But I would argue a deep literature, I think, in terms of many of us that have been doing this work over many years, and to really kind of read that and engage, the interventionists that have been doing community-based research for a long time, even though now you're applying it more from an implementation science framework. The methodologies and some of the frameworks that we've been doing, I think are wholly applicable, here, before the need to recreate something new from scratch that may or may not be necessary.
That's right. Thank you so much. Yeah, definitely no recreating wheels. If you don't feel like you have the skills for engagement, reach out, find a new friend, diversify your research team. I think that is definitely a great take-home message. Do we have time for one more question? David, April, Sarah, how much time do we need to close out with?
I would love about 2 minutes to close out. So if you think you can do a rapid fire round, by all means, ask one more question.
Oh, goodness. Okay. Well, Paul, you mentioned facilitation skills. So if you have any recommendations for where they can get facilitation skills, pop them in the chat to everyone. That would be helpful. And I don't know. I feel like we covered questions.
Yeah, I don't have any particular reference. It's, I think it's mostly a recognition that you have to use facilitation skills, right? And understand that the facilitation in and of itself is an intervention to do this, right? It's a skill set, and there's lots of different facilitation styles.
Yeah. Okay.
Well, Aubrey, with that, if you don't mind if I jump in and go ahead and close things out for our time together, I want to echo Aubrey's thanks to all of our panelists, Melody, Lorna, Paul, you were amazing. Thank you for joining us as a part of this conversation. Would also like to extend a very special thanks to Aubrey herself for her effort in moderating today's discussion. She did a tremendous job, and we are really thrilled to be able to continue this conversation. I'd also like to thank Dr. April O for her leadership in the area of health equity and implementation science. We have been able to have a series of 3 discussions, archives of which you can find online, and I would recommend you check them out if you were not able to join an earlier discussion. With that, I would share with you that an archive of today's session will be available online in a few weeks, and we hope to see you in October for our next implementation science webinar. Thank you all. Be well. You may disconnect this time.